Thank you.
Okay, our next speaker is Marta Varela from King's College London. And Marta will speak about imaging to enhance the treatment and understanding of atrial
Arrhythmias.
It's
mostly atrial fibrillation, which is the most common sustained cardiac arrhythmia. Thank you very much for being here. Thank you, Carola, for the invitation. So I'm going to talk about the contribution that imaging and biophysical modeling can have in the field of atrial fibrillation, which is the most common type of atrial arrhythmia. So atrial fibrillation is unfortunately an extremely common disease affecting 35 million people worldwide. It doubles the risk of mortality and comes with a higher risk of all sorts of nasty diseases, stroke, dementia, heart failure, and most of the patients feel rather poorly. It cannot lead a normal life from palpitations, fatigue, etc. And this, of course, comes with a huge economic burden to the healthcare system. So it's quite a big problem to tackle. So I will explain briefly what it is so that the rest of the talk makes sense. You can see a heart there beating normally. This is the sinoatrial node, the pacemaker of the heart. It regularly fires up and sends an electrical signal to the atria, which makes them contract. And from there, the signal propagates to the ventricles, and they in turn contract. And this is the ECG, the electrical potential that you see if you put an electrode on the chest. But for us today, it's more interesting to look at what the electrical potential is doing in each of the cells. So this minus 70 millivolt is the rest membrane potential that cells are when at rest. When they receive a sufficiently strong electrical stimulus, they respond non-linearly by generating this huge excursion of potential that goes up and then slowly goes down again. And in the normal heart, this is quite a large as in the width here, action potential, and it happens very regularly. In atrial fibrillation, however, in the atria, some rogue cells have become pacemakers and have overtaken the sinoatrial node. So you can see here the propagation of the electrical signal is extremely complicated. The contraction is therefore very irregular and weak, and the ventricles end up beating faster than they should. And if you look at the action potentials again, they're shortened, they're faster, and they're more irregular. And as a consequence, the heart contracts more poorly and pumps blood less well. So for treatment, you can do a cardioversion, which is just a defibrillation of the atria. You give a large electrical shock and hope by doing that the sinoatrial node would take over as the pacemaker again. Unfortunately, this is not, the efficacy of this procedure is less than 50%. You can also give drugs that change the properties of the cell to try and counterbalance this effect, antiarrhythmic drugs, again often with side effects, not very successful. And another procedure which is increasingly common is to put in a catheter into the heart from a peripheral vessel and then burn bits of the atria that you think are hosting the rogue electrical circuits responsible for the arrhythmia, in the hope that will terminate it afterwards. Again, unfortunately, not so successful in general. Or you can just forget about treating AF altogether and just minimize the risks of having those nasty comorbidities. So why is treatment so poor? I would say there are two main reasons. One of them is that the mechanisms that drive the disease are very unclear. What is the nature of these rogue electrical circuits that go on in the heart? It's an open debate. And another problem is that treatment is not personalized. You don't have biomarkers that can help you guide a decision if this patient would respond better to this treatment. You're just trying everything in the hope that something will work. And I think that's why this is a really interesting problem to tackle with our kind of tools, namely developing imaging techniques and data analysis techniques that can help guiding this biomarker creation, and also with modeling, where with modeling I mean creating biophysical models of how the electrical potential propagates in the heart to try and get some ideas of what mechanisms you expect to see driving the arrhythmia. And what I'm going to show you now is kind of the work I've been doing along these lines for this disease. So I'll show you briefly 3 studies, one about in silico testing of drugs, another one about developing a new marker, atrial wall thickness, and finally a shape study of the atrium. So for the in silico testing, I'll start by briefly giving you a recipe of how to create a biophysical model of atrial fibrillation. So you take a high resolution image of the atria, segment it, and you can assign different labels depending on whether in the right atrium or the left atrium or in other areas. You're also interested in knowing what the orientation of the fiber field is. So the cardiac cells are elongated, they're not spherical, and the electrical signal propagates faster along them than across them. So that's important for your model. Finally, you need to assign the appropriate electrophysiological properties to the cells in your model. So these are the action potentials in different regions of the atria. You can see in this region they're slightly longer, this one they're slightly shorter, and that's because the ionic channels, the proteins in the membrane that let ions in and out of the cell, have slightly different properties in these different types of tissue. So finally, you assume that there's a source of abnormal electrical activity here near the pulmonary veins, which then propagates across the atrium, and that you can model the propagation of this signal using this model. So this is just the anisotropic diffusion equation, and this term here has the ionic currents that give the nonlinear response of the tissue. So this is what you get when you do this. I'll explain this movie fast. This is a movie of the propagation of the electrical signal in the atria, posterior and anterior view. The red bit corresponds to the rise of the action potential, and then the color goes down until dark blue is when it's going to rest. And you can see the sinoatrial node is in this region. It's not where the waves of electrical signal are emanating from. They're forming a loop here around the pulmonary veins. And you can also see some kind of spiral waves here and here, if you pay attention, which are not linked to any obstacles. So this is what we think is happening in atrial fibrillation. So we've created a model of AF. So with this model, we can do some testing of drugs. We can change the properties of these ionic channels to mimic the experimental data we have about how different drugs work, and see which ones will work and will terminate the arrhythmia and which ones won't. So this is what we did. We tested two different types of drugs. One mimic amiodarone, which is A, and V for another drug called vernicalent at 2 different doses. And we changed some of the parameters of the ionic channels according to this graph. And then we mimicked the administration of this drug in the heart by changing the properties. In some cases it did very little. In others it actually terminated the propagation of the electrical potential, as you see in this example here. Oops, so it was going to terminate if I let it go a bit longer. So that kind of leads us to the question, what characteristics do successful drugs have? Can we distinguish the ones that are going to lead to a termination of the rogue activity from those which will have no effect? And we tried all sorts of different metrics, and in the end what we came up with was that the drugs that extend the width of this action potential work best, but if they extend it such that they create a large heterogeneity in action potential duration, then they will also be ineffective. So you have a balance between how much they widen this response with how much they widen it in different ways for different cells, and that's what's being shown here in this histogram. We have the action potential duration for different number of cells, baseline in blue, amiodarone in yellow slightly longer, vernicalent even longer but much wider, which makes amiodarone have the better balance and be more effective in this case. So we're kind of testing this in different drugs at the moment as well. So I'll move on to another project where we looked at the role of atrial wall thickness in the mechanisms of AF. First, we developed a new technique to image atrial wall thickness using MRI. This might seem like a strange idea, it was to me, but nobody knows how thick the atria are. Some people have done studies in cadavers using calipers, and they find quite different results. Some people have used CT, but the contrast is quite poor, and certainly no one had used MRI to look at this. So we developed a new inversion recovery-based protocol, segmented it, built some meshes, calculated the thickness using a very simple dual nearest neighbor protocol, and we were able to create a map of thickness, with red being the thicker regions and blue the thinner bits. And then we could register all these maps together for different subjects to create an atlas of atrial wall thickness. So these are the images from MRI and the segmentations, the meshes that we created for 2 different subjects in 2 different views, and then the atlas that we got by registering the data from the different subjects. And you can see here in the right atrium there's a thicker region here called the crista terminalis, where for the left atrium actually the thickness was quite homogeneous and about 2 millimeters throughout. So if you compare it with those studies that I was talking about from CT and cadavers on a region by region basis, that's what these histograms are showing. They're actually quite similar, the results, although there's a large variety in the data. So we created a tool to image atrial wall thickness. So what is this useful at all? That was what we tried to answer using modeling. And before I show the results that Aditi, who's a PhD student I co-supervise, found, just tell you a little bit about the mechanisms of AF. So some people believe that the main rogue circuits that create AF are called rotors. They're just the electrical signal going round and round as a spiral wave, and there's a lot of debate as to whether that's the case or whether we can actually see it when we look at clinical data. But they're very handy because they're easy to create in a model. So this is the spiral wave. You can see here this we call the wave front, where the highest potential is, and then this is the wave back when it's returning to rest. And you can track the tip of the spiral wave. It makes like this beautiful epitrochoidal, like flower-like pattern, and see what it's doing. So that's exactly what Aditi did. She created a rotor in this flat slab of tissue with uniform thickness, and it just kind of went round making a flower here in the middle. And then she did the same thing, but with a gradient in thickness here, a step. And so that it actually, the rotor behaved very differently and started drifting along the gradient in thickness. So she did this for quite a few different step sizes in thickness and starting to rotor in different positions, and she always found this behavior that it drifted towards the gradient in thickness and then alongside it. So this provided some evidence that gradients in atrial wall thickness might be important for the electrical behavior that we see in the atria. So with this was kind of, as this is very simplified system, maybe this doesn't occur in the thicknesses that we see in the atria. So then she took the maps that we'd found from some of the subjects we scanned and initiated rotors again in different positions, in 9 different positions, near this crista terminalis structure that had a higher thickness compared to the rest. And she found that in most cases, here 6 out of 9, 4 out of 9, the rotors did drift towards the crista terminalis and then along it, as she'd seen before in the other models, and some just went elsewhere in a kind of unpredictable pattern. And then as a control case, she also took the atria of subjects where the crista terminalis was not thicker than the surrounding atrium, and there she only saw this kind of unpredictable behavior, which again shows that this is likely to be an important factor in atrial arrhythmias. And this is actually interesting because this region of the crista terminalis in the right atrium is the site of known atrial arrhythmias in many patients. So this was quite interesting, and Aditi is now comparing different contributors to the behavior of rotor, seeing if you're in a region with high curvature, would that win over the high thickness gradient, or with fibrosis, or with other modifications of the atrial tissue. So just to finish, I'll talk about something slightly different again in the context of atrial fibrillation, and this was a study we did to look at atrial shape and whether it had any impact and whether we could create some predictors of outcome by looking at the shape of the atrium. So the hypothesis is that patients who've been in AF for a long time adapt to the disease. This is called remodeling, and part of the remodeling involves the atrium changing shape and size. And this is not an idea of ours. People have been looking at left atrial volume, left atrial diameter, and even left atrial sphericity, which is a marker of how round the left atrium is, as markers of outcome through this remodeling process. But because they had only looked at very specific shape and size metrics at a time, we wanted to do things a little bit more numerically, more computationally, and do an analysis of the whole shape of the left atrium to try and understand which of the shape features would be most predictive of outcome. So we used the data set from 144 patients that had just undergone catheter ablation, and they followed them up for 2 years to see which ones relapsed into AF, had recurrence, and which ones didn't. So the methods were very simple. We took the segmentation of the left atrium from MR images and then fitted this spherical mesh that we created to registered it to the shape of the segmentation to create a left atrial mesh for each subject. And then we registered them all together into the same space so that we could do statistics on this space. So something obvious to do is to create a mean shape, and you can also create a mean shape of the patients that experience recurrence. That's this white mesh with blue wireframes versus a mesh of the patients who did not experience recurrence, which is the one in yellow. And they're quite similar. And so to try and tease them apart, we did the principal components analysis, look at the main modes of variation of shape, and then a linear discriminant analysis on this to try and pick out what the main distinguishing features between the orange and the blue meshes were. And once we'd found those, we could artificially enlarge them and look at what we thought the main differences were. And just because we were keen on creating metrics that clinicians could relate to, we tried to come up with something that we could be guided by this image. So we created this metric that we named vertical asymmetry. We found that recurrent meshes from this viewpoint look like triangles with a vertex pointing downwards, whereas the non-recurrent ones look like triangles with vertices pointing upwards. And we created a metric to try and capture that. That metric we called, as I said, vertical asymmetry, and if we compared it to the other metrics that we were using, had a quite comparable predictive power, and also when we coupled it with sphericity, it did slightly better, but still nothing very extraordinary. And if you look here at the histograms from the patients that experienced recurrence and non-recurrence in this parameter space, they're quite close together. So we could not come up with a magnificent metric to distinguish patients that experienced recurrent from those who didn't from this shape analysis. But of course, if it goes wrong, it's not our fault. It was the data's fault. That was our conclusion. And so we thought that maybe because the atria was static and we were looking effectively at an average shape throughout the cardiac cycle, we'd lost quite a lot of important information there. So right now, we're doing the same thing, but on meshes that change through the cardiac cycle so that we can capture the shape for different phases of the cardiac cycle and compare it there. And an obvious extension of this is to look at deformation metrics, strain and strain rate, and other deformation parameters to try and see how they are affected by how they are linked to the outcome of these patients. And so this would be quite a very statistical predictor in that it would be just coming from correlations that we'd see, and we like to understand where it would come from. So to do that, we are designing these simulations where we run the same simulations that I showed you previously in a static atrium. This is a 2D version in a flat sheet to the atrium, and then one where the mesh is actually deforming. And we hypothesize that the deformations in the mesh will change the behavior of the electrical propagation and will give us clues as to why these shape metrics affect the outcome of the patients. So the idea here being this, what I was telling you in the beginning, that by using imaging and modeling we can get better predictors and a better understanding of the disease mechanisms together, and hope to allow better treatments to be found. So thank you for your patience until the very end, and I'd be very happy to take any questions.
Thank you, Marta. Questions? Yes?
Let's get a bit routine. You have quite a pipeline there of like steps between getting the image to getting the result. And I always, when I want to know the question is when someone says we use registration, how did you validate the accuracy of the registration? Because there's a lot, I find that registration is very non-generalizable a lot of the time. Can you tell us about that specific step?
You mean for the last bit I told you about with the that's a good question. I guess we'd done it for other projects with the ventricles, and there we'd done some validation. So here we just assumed that it would work well with the atria as well. So we didn't do anything more sophisticated than visual inspection to make sure that it worked. It's a pipeline. The registration algorithm has been used for many years in all sorts of data, and I know it's been tested very rigorously before. So I didn't do any specific tests.
You're not testing out just a little look and just double check it and make sure it's working as intended.
Yeah, of course. So one of the issues is that if the atria are very spherical, then it's hard to kind of keep track of what are the different orientations. So if it's spherical, it might be that the algorithm is tempted to just twist it for 90 degrees, for example, because it can't tell the difference because everything's symmetric around that axis anyway. So I did check for those kinds of things, and I checked by looking at overlaying it with the segmentations in the image space and making sure that it was oriented appropriately. But anything very quantitative, like it gives an error of this much %, that I didn't do. Just visual inspection.
I had one question about the last part where you said when you deformed the mesh, then you had this change
yes.
of the spiral. Doesn't it also depend on the resolution of the mesh?
This is actually done in not very significantly, I mean, this is work I'm starting to do, so I haven't got a feel for the data yet. But the basic framework of it is to get a deformation field from the meshes, and that will depend on the resolution, and then feed it to the to differentiation in that diffusion equation that I showed before, and that will change the propagation of the electrical signal. So I think it might, now that you say that, it will be dependent on the resolution of the actual images, but then not so much of what the grid you choose.
Mesh. I'm talking more about the resolution of the mesh.
Maybe, but that's 0.3 millimeters, so that's already much smaller than the actual resolution of the images, so it will require some interpolation, but that might be something interesting to look out for.
If you already sub-image resolution,
yeah, but it will, I think the bigger, the resolution is much coarser in the actual imaging data, so I'd imagine there it might be where we have a few errors by having a coarse resolution.
When your student looked at the flower simulation correlated with the wall thickness,
yes.
You showed that maybe in half of the cases when you were starting somewhere close to this area where the thickness was more, it actually had an effect and it went down the gradient.
Yes,
and
exactly.
Others not.
Yes, so that depended on the... because how close, so we think of it as attractors, so if you're close to it then you kind of sense it and the rotor will be driven towards it, whereas if you're far away, the size of the...
these results by saying, depending on how close you are, you're definitely going to go down the gradient.
And how close you are is a function of how big your flower is, and which is a function of the mean conduction velocity and things like that. Yeah. So if you have a large flower, then you're experiencing larger fields. It's so complicated because curvature plays a role, and everything that changes how many cells are linked together. So when you're propagating the potential, how many cells you have to distribute your potential through will affect all this behavior. So there are a lot of competing factors. Yeah. Yes.
Is there any way to
I guess, check the other things that happen in the tissue, so sort of fatty infiltration or
Yes,
fibrosis.
so that's something,
you know.
yeah. So fibrosis is a huge topic. Everyone is super excited about how fibrosis is going to be the biomarker that will change everything. So fibrosis in MRI is measured with late gadolinium enhancement, which is just the idea being that gadolinium, which is an MRI contrast agent, gets trapped in the extracellular space, which is larger in the areas with fibrosis compared to the other ones. But the resolution is super poor, and it's all very subjective in that, because the MR intensities depend on so many parameters. People just go and say, looks brighter here, must be fibrosis, looks darker there, it's not fibrosis. And then you can add the fibrosis. That's something Aditi's done subsequently, but I didn't have time to show. She added the fibrosis from these images to the atria that we saw over there, and tried to see which would win, the gradients in thickness versus the fibrosis. And in the left atrium, there are no gradients in thickness, so the fibrosis wins every time, and the rotors tend to kind of go around the fibrotic areas. For fat, we've tried a couple of Dixon sequences, but it's tough in the atrium, so we haven't had much luck imaging fat, but I think that would be really interesting as well.
What do they change in the model?
The fibrosis? The fibrosis changes the conduction velocity. So in the equation there was a diffusion coefficient. It basically changes the diffusion coefficient. It's lower there because the cells are less well coupled, and the fibroblasts act as insulators basically there. And you can also change the anisotropy, and different people kind of do it in different ways. So you can have kind of holes in your mesh. Yeah. And all of these changes, because as I was saying, affect the number of cells, how the cells are connected, affect the behavior of these rotors throughout.
Thank you. No more questions. Let's thank Marta again.